Today's topic is adrenergic agonists, and the adrenergic agonists directly or indirectly stimulate adrenergic receptors alpha or beta, and the direct acting uh, adrenergic uh, drugs include the non-selective epinephrine and norepinephrine, and also selective uh, isoproterenol, uh, that is a beta selective, and alpha selective phenylephrine. So these are the direct acting adrenomimetics. Indirect acting adrenomimetics include uh, completely indirect, like cocaine. Cocaine is not a drug, but a drug of abuse, but used for the some procedures in ophthalmology in some countries. And amphetamine is also a recreational drug and not a drug, a medicinal drug, but in some countries also can be used for treatment of the hyperactivity in children. But in most countries, it's also uh, it's not registered as a drug, as a medicine. So, and then the mixed action that are direct and indirect, but mostly indirect, are ephedrine and the derivative of the ephedrine, pseudoephedrine. So these are this is the classification of the uh, adrenomimetics, or drugs that stimulate adrenergic receptors. And uh, as far as you remember, the sympathetic nervous system has a postganglionic adrenergic receptors. So uh, the neurotransmitter is norepinephrine, and the receptor is adrenergic receptor alpha or beta, depending on the tissue. And also the adrenal medulla uh, can be supposed to be same as the large neuron that also has nicotinic receptors that are stimulated by the sympathetic nervous system, and the adrenal medulla releases epinephrine into the blood, and then this epinephrine is delivered with the blood to the vessels and heart, and will stimulate the also other tissues, and will stimulate the adrenergic receptors in those tissues. So in vessels it's mostly alpha receptors, and in the heart it is the uh, beta 1 subtype of receptor of adrenergic receptor. And if we look at the synthesis of the norepinephrine, the norepinephrine is synthesized from the tyrosine uh, amino acid, and the precursor is deoxyphenylalanine, or DOPA, and then the DOPA is converted to dopamine, and dopamine uh, is used to synthesize norepinephrine in the vesicle. Then when the vesicle content is released to the synaptic cleft, the a moment the norepinephrine can act on presynaptic adrenergic or postsynaptic adrenergic receptors, and after that it is uh, it is inactivated by the catechol or methyltransferases or COMT receptor. So these receptors are inactivating the catechol amines, and norepinephrine is also catechol amine, and that inactive metabolites are excreted by urine, and also the norepinephrine can be reuptake by the neuron, so it can store it in vesicle again. And so those drugs that inhibit reuptake will deplete the norepinephrine supply, and that will lead to the uh, uh, it will lead to the
More norepinephrine in the synaptic cleft.
yes, norepinephrine is released to the synaptic cleft, but can be reuptake by uh, by the neuron, and then used again, so like stored in the vesicle. So this is the way the norepinephrine is synthesized and also recycled.
Are these, doctor, one question please.
Yes.
Are these drugs called norepinephrine reuptake inhibitors?
Yes, the drugs will like this. There are a separate group of the drugs that are used as antidepressants, and they are called selective norepinephrine reuptake inhibitors, so SNRI. This is an antidepressant drugs. Like the most common is fluoxetine, and imipramine is also among them, but is less common nowadays. Cocaine is also inhibiting the reuptake, so and that but cocaine is by inhibiting reuptake will lead to the increase of the norepinephrine in the synaptic cleft, and that is why it is adrenomimetic. So that is actually will increase the concentration of the norepinephrine. So okay, then let's go to the selectivity and the alpha, and there are two families, alpha and beta, and the these receptors uh, have different affinity for the epinephrine, norepinephrine, and isoproterenol. So isoproterenol or uh, uh, is a better adrenomimetic. So, and that is why it has very low activity for the alpha receptor. So, and the highest activity for the alpha adrenal receptor is with epinephrine, because epinephrine is released to the blood, and in the vessels the majority of receptors are alpha receptors, specifically alpha 1 subtype. Then beta adrenal receptors are predominantly in the heart. So beta 1 receptor is in the heart, but also beta 2 in the smooth muscles, like bronchioli and the uterus, the bladder, etc. So, and beta adrenal receptors are more selective for the isoproterenol. So isoproterenol is a very potent agonist for this receptor, and epinephrine is less, and norepinephrine is even less. So this is the selectivity of different drugs for the alpha and beta receptors. So as far as you should remember from the previous topics that alpha adrenoreceptors are located in the vessels, beta in the heart. So in general, but alpha 1 is in the vessels, alpha 2 is also presynaptic, so this usually alpha 2, and so this receptor is presynaptic. So and what it usually does, it inhibits the release of the norepinephrine. So once there is enough norepinephrine released to the synaptic cleft, it will activate the receptor, and the receptor will inhibit the physical release, so that will prevent excessive release of the norepinephrine.
Negative feedback.
Yes, it's called a negative feedback. Quite right. So and beta adrenoreceptors are mostly located in the heart, like beta 1 are in the heart, but also beta 2 are located in receptors, in the vessels that supply blood to the skeletal muscles. So these are beta 2 receptors, and the stimulation of these receptors will relax the vessels that supply blood to the uh, uh, skeletal muscle. That is why when we run and fight, there is more blood going to the muscles than to other organs. And Also beta 2 receptors are in the bronchioli, and that leads to the relaxation of the bronchioli, and also relaxation of the uterus, because beta 2 receptors are also there. So, and this is the effect of the mostly of the epinephrine, because norepinephrine is mostly will influence the blood vessels, because it's released in the synaptic cleft. So epinephrine is actually in the blood. So actually this slide shows the negative feedback that is with the alpha 2 receptor, and it will block the enzyme that is uh, that is uh, synthesizing cyclic adenosine monophosphate, and cyclic adenosine monophosphate usually triggers the release of the vesicle. So and alpha 1 receptor is usually on the vessel, so this is actually smooth muscle of the vessel, and alpha 1 receptor is a metabotropic one and lead to the activation of the inositol 3-phosphate and deacylglycerol, and that increases calcium, intracellular calcium, and leads to the contraction of the vessels, of the smooth muscles of the vessels. Yes?
Can I ask question,
Sure,
please,
please.
concerning alpha 2 receptor?
Sure, please.
Since it causes a negative feedback, why is it classified as an adrenergic agonist?
The receptor is not classified, and the drug can be classified.
Okay, the norepinephrine will bind to alpha 2 receptor, causing a negative feedback, and even that it's still an agonist. The
Um,
norepinephrine in this case still an agonist or antagonist?
it's still agonist, because agonist and antagonist, uh, the name is given by the action on receptor. So the name is not given by the function of, because drugs will not, uh, drugs are not uh, 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 connected with the function. So the drugs will selectively bind to the receptor, and whatever receptor does, then will be the
It
effect.
doesn't matter.
It doesn't
Okay.
matter. So that's why it's still agonist, even if it's inhibiting release, it's still agonist.
Okay,
So
I get it.
it
It
Thank you.
depends on the signal transduction.
so
Oh,
it depends on the reaction of the receptor. So receptor can be activated or inhibited by the molecule. So, and if it's activated, no matter what happens, then it will be agonist. And actually, norepinephrine is not a drug, so norepinephrine
a
cannot be isolated.
neurotransmitter.
Sorry?
It's a neurotransmitter.
Yes, it's neurotransmitter, and adrenaline is actually a hormone, but adrenaline is also available as a drug. So, but here we still study norepinephrine because of its importance, and it is listed in the classification because it has a common structure with the epinephrine. But you cannot find norepinephrine as a drug because epinephrine has the same properties. So there is no uh, any purpose to produce two drugs with the same effect, almost the same effect.
And doctor, I have one question.
Sure.
In the, it's about adrenaline and the epinephrine. It's just a difference. It's the same molecule, but just a difference in the name, right?
No, it's not the same molecule, but the chemical structure is common. So norepinephrine is the actual epinephrine without one methyl group. So that is why they mostly the same uh, uh, effect on receptors. Like selectivity is almost the same, but norepinephrine uh, is most like epinephrine is stimulating alpha adrenal receptors a little bit less, and norepinephrine a little bit more, but that is usually hard to distinguish. So like if we look at the chemical structure, so this is a norepinephrine. As you can see, if we remove one methyl group from the molecule and replace it with a hydrogen, that will lead to the norepinephrine. So it's like normal epinephrine. So like even the name is close. So and if we look actually at the structure, so we have an amine group on the right. Then we have ethyl skeleton, carbon skeleton, and the benzene group with the 2-hydroxy. So this is called catechol. So this yellow uh, aromatic cycle, a 6 chain, is called a catechol. So and that is why catechol amine. So we have
Yes, the group is catecholamines.
so it's called uh, so actually it's very easy to remember the formula. So when you start studying pharmaceutical chemistry, then if you if you have trouble to remember the formula, just remember that is amine, and this is called catechol. So and they are connected with the ethyl bridge. So this is called bridge, like uh, a millennium bridge is connecting the main building with the pharmaceutical faculty the same way. So like look at this, like this is the main building, this is a bridge, and this is pharmaceutical faculty. So like it's large, like actually not only main building but also new building and other buildings of the university are connected with the millennium bridge. So this is pharmaceutical faculty because it's very small. And then next year, so like recently they built a student hostel near the pharmaceutical faculty. So this is a student hostel with a methyl group that increases selectivity to the beta receptors. So norepinephrine is more alpha and epinephrine is more beta. So and then the scientists compared this formula, and they thought if we further increase this this residue, and what happens, and they try to increase, and then the isoproterenol even most is become even more selective for the beta adrenal receptors, so much selective that it is called completely selective beta receptor, so it will not activate alpha receptor. And the name is iso because here it is propane, so 1 2 3 3 carbon is a propane, but it is not in the one line, it is isomeric of propane, so that is why it isoproterenol. So isopro means propane, and isoproterenol is actually the end of the drug, because there are two hydroxy groups here, it is all at the end. So this is the one of the first selective beta adrenomimetics. And if we compare with the ephedrine, ephedrine is not a catecholamine, and that is why it has much longer duration of action. Like, for example, norepinephrine is not effective, so injected into the blood, destroyed very fast. Epinephrine is short duration of action. Isoproterenol is longer acting, but still is destroyed by catechol or methyltransferases because it has a catechol group. But ephedrine, it's derived from its alkaloid of the drug, of the plant, is not a good substrate for the catechol O methyltransferases. So because they require catechol group, but here we only have phenyl group, so that is why this F drug has a longer duration of action, up to several days. But the structure is almost the same. Like here is epinephrine. Like if we compare with the epinephrine, we have methyl here, same, but hydroxy group here, same, but we only have a additional methyl group at the alpha position. So as you can see, the structure is almost the same. And then dopamine is also produced in the body, also is catechol, but the nitrogen is primary, and also there are no substitutes in the ethyl bridge. So ethylic bridge is actually without substitutes. So dopamine is the neurotransmitter mostly in the central nervous system, is vital, also in the peripheral, but mostly important in the central nervous system. And the lack of the dopaminergic neurons leads to the Parkinson's disease. So, but we will study that later at the next section. Then indirect acting drugs are we already started talk about the indirect action. But generally there are two subtypes of the indirect action, drugs that only make the indirect action, and that can be by increasing of the release of the norepinephrine from vesicles, and some of the drugs also will have mixed action, so they not only increase the release of the norepinephrine but also stimulate the receptor directly. So this is the most common of the drugs, like ephedrine and pseudoephedrine. And if we look at the effects of the drugs to the heart rate, then the blood pressure, and peripheral vascular resistance, so then we can see the difference between the epinephrine and norepinephrine. So, and now I will try to explain you why that happens, and that is because of the different affinity to alpha and beta adrenoreceptors. So this is the epinephrine that is injected intravenously through the system, and then we can see that epinephrine increases the heart rate and contractility of the heart because of the stimulating of beta 1 adrenoreceptors in the heart directly. So then if we look at the blood pressure, then systolic blood pressure will increase because of the stimulation of the alpha 1 receptors in the vessels, in the aorta and large vessels and veins as well. So but diastolic blood pressure will decrease because epinephrine also stimulate beta 2 adrenoreceptors that go in the smooth muscles going to the skeletal muscles, and this that will lead to the decrease of the diastolic pressure. And then if we look at the peripheral resistance of the vessels, so the resistance of the vessels uh, is usually increases because of the contraction of the vessel, so the peripheral resistance is decreased. So that is actually most of the time it's good. If we look at the norepinephrine, then we will see the exactly opposite. So norepinephrine will lead to the reflector bradycardia. So because of the very high increase in the blood pressure, it will like not directly, but uh, increase in the blood pressure will stimulate the vasomotor center, so in the brain, and then that will send a signal to the parasympathetic nervous system that will be activated, and that will decrease the heart rate, so lead to the bradycardia. And then both systolic and diastolic pressures are increased. Blood pressure is increased dramatically with the norepinephrine because norepinephrine mostly will act on the vessels. And then because of the high increase in the blood pressure, also the peripheral resistance increases very much. Um, because norepinephrine will also constrict not only large vessels but also the small vessels. But as far as you remember, the peripheral resistance is mostly done by the small vessels like the capillaries, arterioles, and these small vessels will also contract, so that is why the peripheral resistance will increase. But with the epinephrine, small vessels are relaxed, that the small vessels that go to the skeletal muscle, they have beta 2 receptors. Stimulating of beta 2 will lead to the relaxation. So that is why the diastolic pressure is decreased. So because of the decrease of the peripheral resistance. But here peripheral resistance is increased, and that is why diastolic pressure is also increased. And epinephrine is most of the widely used drugs because it can be injected parenterally or usually intravenously, intramuscularly, and subcutaneously as well, and also intracardially with the uh, with the sorry with the special with a special needle that will goes directly to the heart in case of the uh, patient's heart stop beating. So and also will not penetrate to the central nervous system. That is good because central nervous system action is not very pleasant. So and then can be used as an aerosolic way. So usually not epinephrine itself, but selective beta 2 genomimetics that will relax the bronchiole and trachea. That is good for the asthmatic patients, and then is released by the urine. So this is the epinephrine. And the isoproterenol is the first selective beta-adrenergic, and can be used for the uh, relaxation of the bronchiole in the asthmatic patients, then in the dilation of the peripheral blood vessels. It also can increase the heart rate and contractility of the heart, and also will uh, uh, dopamine actually has two major effects on the periphery, like increasing the heart rate and increase in the blood flow through the kidney. So, and kidneys will usually feel the increase in the blood flow and try to decrease and the blood pressure. So, and as a uh, anti-asthmatic drug, epinephrine is seldom used because it's very short duration of action, and the most commonly used drugs include terbutaline, albuterol, and long-acting formoterol and salmeterol. So, terbutaline and albuterol are used for the uh, for acute bronchial asthma attack, whilst formoterol and salmeterol can be used for the prevention. So all these drugs will lead to the bronchodilation. They are introduced as an aerosol by the inhalation, and are very effective, very much effective than uh, the cigarettes of the atropa leaves. So the first drugs for the asthmatic patients was uh, the atropine from the cigarette of the leaves of the Atropa belladonna. So and like any other cigarette, it was it was increasing the inflammation because of the smoke. Okay, so and the adverse effects include the arrhythmias, because usually tachyarrhythmic forms of the arrhythmias. Then headaches are most common adverse effects. Hyperactivity in children, usually in children. Insomnia, usually in adults, like the younger age adults. And nausea, in case of the some uh, people that are uh, prone to the nausea, and tremors can be seen in high doses. So, except that there are uh, almost no adverse effects. So, and these drugs are very safe. So, that is it for today. And so, do you have any questions left?
Yes. Okay, go ahead. Go ahead.
Okay, when we talked about the epinephrine and its role in the contractility of systole and diastole, I know that in the heart there is a law named Starlink's law, and this law says that more contractility will give more relaxation in the heart.
No, it's vice
So
versa. The higher is relaxation during the diastole, the stronger the heart will contract during the systole.
okay, so it's Starlink's law.
Yes.
Okay, so I saw that when you showed us the picture, the curves, I showed that the epinephrine will cause will not allow this more relaxation because the pressure will still high in both systole and diastole. That's it.
There is no pressure in diastolic. So the pressure is only during the contraction of the heart, and the
Okay.
diastole is because of the relaxation of the muscle during the refractory period. So it is not controlled by the epinephrine.
Okay, okay. So I misunderstood. Thank you.
And sometimes relaxation of the heart can be increased by the volume of the blood that is delivered by the veins. So if the pressure in the veins is high, they can even stretch the heart, and that can lead to the increase to the heart pressure and pressure to the valves of the heart, and that sometimes leads to the uh, failure of the heart. So uh, like, because it also increases the contraction rate, and if the heart is the muscle is not trained, that can lead to the congestive heart failure and also development of the cardiovascular diseases.
Okay.
So like epinephrine is will increase contraction. So relaxation is actually, you cannot measure relaxation because it's the absence of contraction, like zero.
So there is no contradiction between epinephrine and Starlink's law.
Contradiction, there is no like
There is no contradiction because I thought that this contradiction will give us arrhythmia.
arrhythmia is not because of this contradiction. Arrhythmia most of the time is because of the different parts of the heart are contracting, uh, not synchronized. Like first the atriums should contract. So the first so like the blood goes to the atrium and then goes to the ventricles. So that is why uh, atrials should contract first and ventricles should contract after them. So, but if they contract simultaneously, then the blood will not flow from the atrium to the ventricles, and that can lead to the. Uh, so this is one of the uh,
Reasons of
types
arrhythmia.
of the arrhythmia. Then
Okay.
arrhythmias can be by the tachy and bradyarrhythmia. So if the heart rate is not yeah, like is not uh, is not normal, like higher than the normal or lower than the normal, or if the right and left parts of the heart can contract in different the
Not synchronized.
yes, also not synchronized, but mostly the ventricles and the atriums should be synchronized. So, and sometimes the nerve the uh, nerve system of the heart is damaged, and that is why just the usually the stimulation is goes from up to down heart, and then if there is the damage, then it can travel in opposite direction, and then will lead to the additional contraction of the atriums, but ventricles will not contract at all. So
Uh-huh.
there are many types of the arrhythmia, about 100 types, and unfortunately, it's not part of the pharmacy course, but so there is like a special subject for that, and it is only available in the medical for the medical students for the
Mhm.
physicians.
Okay.
So, and also it's very like the
Large.
electrocardiogram is used to detect the type of the arrhythmia. So,
Uh,
so we will study antiarrhythmic drugs and we'll go in detail about the arrhythmia. So it's very interesting. There are many of drugs, and there are many types of arrhythmia. Even there are some types of the arrhythmia that are caused by the drugs only. Like special, there is a special type of the arrhythmia. It's the QT prolongation is caused by the all anti-arrhythmic drugs, and also but some other drugs like haloperidol, antidepressants, antibiotics as well. So like many drugs can cause arrhythmia. So that is why it's not recommended to combine these drugs. Okay.
I
Any?
see.
You're welcome.
Thank
Any?
you.
Karim, you also had a question.
Yes, it's about the adrenaline or epinephrine dump. It's associated with the sympathetic nervous reaction. Sometimes, like in people like are chased by a dog or in a fight or in a nervous situation, that in that situation they are able to exert very strong and abrupt effort, like for example run very fast or be do something like very strong but just for a short amount of time. But after this they have this adrenaline dump so that they can't do anything and they feel very tired. Is it due to the inhibition of alpha receptors by adrenaline, or is it done by the that this adrenaline can't be recycled by the enzymes and return to the presynaptic neuron?
Oh, adrenaline cannot be recycled by the nerve endings because it is not a neurotransmitter. It is a hormone. So as a hormone, it released to the blood, and then it acts on the mostly on the heart and vessels, but also can distribute to other parts of the body. So and the the people after this release, the tiredness will be not because of the action of the epinephrine, sorry, the adrenaline, but because of the deplete of the norepinephrine in the synaptic ending, sorry, in the nerve endings, in the vesicles, because there is a limited and very small amount actually of the norepinephrine, and once it's depleted, it requires several days for full recovery.
Oh, okay, I get it.
So that is why,
It is short acting, but in order to recycle it and have it back in the presynaptic neuron, it takes time. It takes a long time.
yes,
It's
it's
like
take
short acting, but to recycle it takes a long time.
like if you deplete it, because usually it's released in the about the same with the same speed as it is recycled or resynthesized. But if we increase the intensity, like for a very short time, we have very strong contraction, and that leads to the release of the all of the norepinephrine in the small amount of time. Uh, that will require recovery. So, like,
Yes, got you. Thank you, doctor.
you're welcome. Any other questions, ladies? Nada, Mina. Okay, if
Yeah,
yeah.
everything is clear.
Yeah, okay, good. Thank you very much for attending the lecture, and see you next week. Bye bye.
See
Thank
you.
you.
Bye
Bye
bye.
bye. See you. Goodbye.